Hi, folks. Nice to interact with you again. So, I'll be making a short podcast on Procal and CRP, something which is very important. And some of our colleagues and members that asked me also, and I'm sure it'll be helpful not only to him but and the others, but everybody. So, first PCT. Now, it's very important to know about PCT and Procal, sorry, CRP. Why? Because mainly it helps to diagnose or exclude sepsis. And everybody knows what is sepsis in the ICU. It's the biggest killer. So a thorough understanding of CRP and Procal is important. However, having said that, you need experience also. You have to use Procal and CRP at the bedside, see the patient and realize the caveats, the pitfalls, the false positive, the false negative before you can actually become comfortable. It takes a little while. So this is the theory, and I'm very comfortable with PCT CRP. I've seen so much of it, and I know how to use it. So, and I'm sure all of you will also get to use it, know about it as you go along in your career. But first, the theory is important. And of course, you're already using it. So, you are at different stages in the curve for PCT and CRP. So, now I'll start with the case. This is actually very much from our own channel, Dr. Ranjit. Many of you must have seen his comments also. Just a couple of days ago, he said that we have a neurocritically ill patient. He underwent craniotomy, and I think that was for a TBI. And then he had persistent fever, and his CRP was more than 300, and Procal was near normal, zero point 0.5 or something. So what can it be? Is this sepsis, infection, or is this because of a CNS infection that Procal is low? What is happening here? Because Procal is normal, but CRP is more than 300. So can this be sepsis? Can this be a CNS infection? Does this happen only in CNS infection? Because he had seen a couple of more cases recently like this. And the patient was having fever, recurrent fever. So what do you think? If the Procal is near normal or normal and CRP is 300, can the patient have sepsis or not have sepsis? So guys, Procal can be normal in sepsis. I think most of you must be knowing that by now. It has a sensitivity of 80% and a specificity of 75% for the diagnosis of sepsis. A normal Procal does not rule out sepsis at all. So I've seen patients dying with a normal Procal and even a normal CRP. It's not common, but it happens. And because sepsis is common, this happens frequently enough. Now, what is happening in this patient now? He was 300 CRP, Procal 0.25 or zero point 0.5, and he was having fever. So most likely, he was in the post-surgical state. The post-surgical state, the rise of CRP and the Procal may not rise. Why? Because CRP is actually a marker of inflammation, but most importantly, though it rises in many conditions, we'll get to that. And Procal is a marker of bacterial infection and sepsis, and less of a marker for inflammation. So that was probably what was happening in this patient, and the fever may be post-operative fever or maybe central fever because of TBI, something like that. He didn't put all the details, so that was my explanation to him. Now, uh, moving on with Procal. Where does Procal come from? So Procal is the precursor molecule for calcitonin, which is secreted by thyroid. Earlier, it was thought when Procal was discovered as a marker for sepsis that it comes only from the thyroid, but subsequently it was seen that even in patients where thyroid was removed, for cancer and all, Procal used to rise. So it was found that in sepsis, it can come from various other tissues. So just let's keep it at that. Rest is not so important. Now, apart from that, what other features of Procal are present in sepsis? So in sepsis, when I told you that you can have sepsis and septic shock and patient can have the normal Procal, brand normal Procal. Then how do you use it in sepsis? So in sepsis, the main use is to stop antibiotics. So you have a Procal at time of admission, the septic shock is diagnosed, or sepsis multi-organ failure, and when it becomes 80% of its initial value and clinical resolution of sepsis, you can stop antibiotics. That is the advocated method for the use of Procal. Apart from this, its use is in following kinetics. So you do a Procal in a patient who does not have sepsis, all right? Or who has sepsis, sepsis resolves, patient still in the ICU, and then Procal has fallen, and then suddenly it rises. So you know something has happened. It may be sepsis again, maybe infection, maybe not. So that is kinetics. It goes down, resolves, and then goes up again, or is normal and then goes up again. So these are kinetics. You can use it to follow the trends in the patient to make out what is happening. Now, sepsis is one cause. What are the other causes of Procal? So there are multiple causes. All causes of SIRS can cause, including cardiogenic shock, pancreatitis, burns, polytrauma, many other causes of shock, severe shock. So Procal goes up. Now, when does Procal not go up? So here it's important to realize that in viral infections, Procal does not go up because in viral infections you get secretion of interferon gamma, and this actually kind of inhibits Procal. So in viral infections, it does not go up, but these are viral infections which are not, spilling over and causing multi-organ failure or shock. Viral sepsis also occurs. So if that is occurring, then Procal will go up. So in COVID, if there's initial just an infection which is not overwhelming, or in influenza, or in dengue, you can get a normal Procal. And once it spills over and causes devastation, then Procal will go up even in these conditions. Now, the other situation where Procal is important and it does not go up is in autoimmune conditions. So in autoimmune conditions like SLE, rheumatoid arthritis, vasculitis, the Procal remains normal or rises mildly with severe inflammation. Here in these conditions is actually CRP which goes up. That is another discordance between CRP and Procal. And in SLE, actually CRP does not rise, and that's the paradox of SLE and CRP. Unlike all other autoimmune conditions where CRP goes up, when there is inflammation, and that depends on the severity of inflammation. It can be followed to assess the inflammation in these autoimmune conditions. So, moving on to Procal. Now, what happens in liver disease and kidney disease? So, in both liver and kidney, you have clearance of Procal, mainly the kidney, but also to some extent in the liver. And in kidney disease, acute or chronic, it can rise up to 1 unit. Okay. So if it is 1 unit, whatever the unit the lab is using, I don't remember exactly. So if it's in microgram or whatever, so 1 unit per deciliter or per milliliter as the unit may be. So if it's elevated to that point, then it is okay. And you can use it. It is not severely risen. So mild elevation occurs in acute kidney injury and CKD. And in liver disease also, Procal goes up. Procal goes up in liver disease, especially in acute liver failure, because acute liver failure SIRS, there can be a mild rise in CLD, but in acute or chronic liver failure, again it goes up because there's inflammation. And inflammation also makes Procal go up. It's not only bacterial infections, if there's inflammation also, Procal will go up. So mild rise is seen in these conditions, especially CKD and acute kidney injury. However, if acute kidney injury itself is associated with a lot of inflammation or infection causing acute kidney injury, then it will be markedly raised. So all this requires a little experience. But to say that you cannot use Procal in acute kidney injury is incorrect, because classically the rise is not so much. So moving on now, how high can the Procal go and what are the typical values? So the normal value is less than 0.25, and in classic bacterial infections, when there's no sepsis, it can be like 1 to 2, and it crosses 2 in sepsis, and in septic shock it is more than 10, and multi-organ failure with sepsis more than 10 classically. And values more than 100 are also seen, and higher the Procal, worse the prognosis. So this is about Procal. Please remember that it is not necessary that Procal be high in sepsis or septic shock. It can be bang normal, and surviving sepsis guidelines 2021 do not say anymore that Procal is necessary for the diagnosis. It was there earlier, right? And at some point in time in the ICU, you should get a Procal value done, just to keep it there. And if anything happens to the patient, worsening or something, you can repeat it and check again. But overall, don't do too much. Procal is kind of costly, 2,500. CRP is a younger brother of Procal, if I can say so, and costs only 200, 300 bucks. If you want, alternate date monitoring or something, then it's better to do CRP. The cost comes into play, and is much more cost effective. So now I'll move on to CRP. So CRP is a acute phase reactant, just like Procal. Where is it made? Anyone of you knows? So CRP is made mainly in the liver and in macrophages, distributed across. Macrophages also secrete CRP, C-reactive protein. So I told you Procal has a sensitivity and specificity of 80 and 75% for sepsis and septic shock, and CRP is around 5% less. So there's not much of a difference. It works very well. I have been using CRP for a long time because I don't like to, unnecessarily increase the billing by using Procal. CRP works very well in most situations. If there is a doubt, then you can always get a Procal done, or at some point in time, you can get a Procal done as a baseline value. So CRP in sepsis, I've told you. Then what is CRP? CRP is acute phase reactant which responds primarily to inflammation and not bacterial infection. So that is the difference between Procal and CRP. But having said that, there's an overlap. It's not that CRP will not respond to bacterial infection. It's not that Procal will not respond to inflammation. So most of the situations where there is a rise of CRP will be rise of Procal and vice versa. But sometimes it's the other way around, in the sense that the discordance, your CRP is high, your Procal can be normal. Even in sepsis, your CRP can be high and Procal can be normal. Procal can be high and CRP can be normal. Now, where does CRP become high and Procal become normal? So I told you in autoimmune diseases, it's very important, and in low-grade inflammation. For example, if there is a thrombophlebitis causing fever which is not being picked up, CRP will suddenly jump up from 20 to 50, 60. There's a small rise. Similarly, if there's a bed sore, inflammation, the CRP will jump up from 20 to 60, small rise. The Procal will not change. So if there is low-grade inflammation, there will be a small jump in your CRP. What are the typical values of CRP for septic shock? So it will be more than 150, going into 250, 300, 350, depending on the severity and the genetic response of the patient. And what values will you get in sepsis or lesser bacterial infections? So it will be like 100 and less than 150 generally. So that is very important. And in viral inflammations, you can get a CRP high and a Procal will be normal. I told you earlier also, in viral infections, it does not rise unless there's an overwhelming cytokine storm kind of a thing in viral infections. So this is a very important distinction to be made as far as the use of Procal and CRP is concerned in two situations. One is viral meningitis versus bacterial meningitis. Here, Procal remains less than 0.5 and CRP rises to more than 50, 60 most of the times. So using these two, you can differentiate viral from bacterial meningitis. And of course, the CRSF helps. Second is a acute exacerbation of COPD. Here again, your CRP rises small amount, 30, 40, while your Procal remains less than 0.5. As far as AE COPD is concerned, it has three causes of exacerbation. One is bacterial, one is viral, one is non-infectious. One third, one third, one third. Only in bacterial will CRP rise. Otherwise, CRP will also remain normal. And Procal will remain normal in all these three etiologies of acute exacerbation of COPD by and large. Nothing is hard and fast. But this happens in most of the patients. You have to make a clinical diagnosis and you have to correlate with your lab features and take the help of the lab features. You cannot just say on the basis of the Procal and CRP, no, this is this, and I'm sure this is this. So this comes with experience. So you take home the knowledge I'm giving you, take this knowledge to the ICU, apply it, and think about it, and you will gain experience. That is what experience is in medicine. Because no test in medicine is 100%. No test can be 100% because of variation in the genetic makeup of the patient, because of lab errors, machine errors, human errors, and so on and so forth. Now, what else is important again? Liver and kidney. So CRP is made in the liver, right? So if there's liver inflammation, CRP is going to be released and CRP is going to be high. So both Procal and CRP become high in liver disease. If there's a chronic inflammation low grade, then the levels are low. If there's a massive inflammation, then the levels are going to be high. But then again, you can see the kinetics. If the levels are only mildly increased in the beginning, and then you can follow the kinetics of CRP just like Procal. And in kidney disease, again, in acute kidney injury, there can be a mild rise 10 to 20, which is nothing. So acute kidney injury does not affect it, neither does CKD. All right, only patients who are on chronic dialysis can have a 30-40 value of CRP because uh, there's a low-grade inflammation when there's a intermittent continuous dialysis going on. And finally, CRP also has prognostic value, so just like Procal. So, friends, that was what I wanted to tell you about Procal and CRP. But please remember the cost effectiveness of Procal and CRP. Try not to do Procal every day or every alternate day, or as just like sodium potassium, as it happens occasionally. One has to be more sensitive to the financial aspect in the ICU, and one has to do cost effective testing. You can do 10 CRPs for one Procal. And again, I repeat, both CRP and Procal can be normal in sepsis and septic shock. However, a high value in the right context generally means sepsis and septic shock. But there are many other causes of both elevation of sepsis and septic shock, CRP and Procal. And whenever Procal is increased, generally CRP will also be increased, though there are situations where there will be a discordance. Okay, so I hope that was useful. Any comments, please feel free. And we'll be having this International Fluid Academy webinar. This is a global webinar from across the globe with speakers everywhere. I shall put up the program, I think today in the evening by evening or tomorrow. Try to attend it. So I split it up into 3 sessions so it doesn't get, too much sitting there on just listening to and listening. So you can join in morning, lunch, evening, and listen to some of the talks, whatever you like. And it should be very good. We'll have Dr. Malprint speaking. He's one of the greatest people on fluids, and there's Dr. Robert Hahn. Dr. Robert Hahn is just magical. What is peak and PD of fluids? What happens when you give finger saline? How does it distribute to get this fast, slow, and just what is distribution of fluids? You're giving 500 ml of normal saline at 100 ml per hour. How much is going out into the urine? How much is going into the intravascular, extravascular? So the distribution and what kind of intercellular swelling you are getting, fluid distribution, wonderful. He's a total expert on that, and there are other speakers also. So I'll put up the program. So bye bye guys. Put up your comments and any topics you need and anything else you need. Feel free to ask. Of course, it takes a little while. I cannot do things immediately. Even if the lectures are requested, it takes 3-4 months to schedule because the lecture schedule is made for the next 3 months, right? So if you request today, it takes 4 months to accommodate that. So I hope you just kind of appreciate that. And whatever talks you want, like these kind of talks, small talks, I can take up as and when I get time. I try to do it as soon as possible. So thank you. Thank you for all your support, all your love, all your financial support. And please keep it coming. The financial support is very important. I shall try to keep on improving and improving. And hopefully, we can start a website also where I can do more things for everybody. So, guys, take care. Bye bye. God bless.